So I can meet my quota of 3 cases and not be yelled at. All right, so this is a patient who has a history of breast cancer and had some liver lesions that were detected on some study or another. And here's their liver, had a lesion, a little lesion. Here's the T2 weighted imaging. So they were interpreted to basically be benign, and no one got too concerned about them. On this scan, there's an important finding, which I like to talk about when I staff out trainees, so I figured I'd show it to the group for fun, is that sometimes patients have imaging findings on one sequence that are not present on any other sequence because of how high up or low down the sequences go. And one of the places I always have part of my search pattern when I'm searching for things is things that are at the very tops and the very bottoms of the images to make sure that you don't miss something that's cut off of the other field of view. And this particular person on their localizer sequence has this little thing right here. And on the post-contrast images, it's right there. It's on the first image. And they had a personal history of breast cancer, but this wasn't known about. So we called them and said the liver lesions are probably fine, but they have this finding in the breast, and they got biopsied, and it was invasive breast cancer. So we've seen a few of these, and I'm sure you guys have too, where you see a clinically significant incidental finding. My general take on incidental findings is they're all terrible and garbage and worthless, but there's a couple few that I think are really important. And for me, I think one of these solitary breast cancers are really important to find. You could totally change somebody's life. I've gotten a couple of emails from patients and referring providers saying a lot of nice things about finding these small breast cancers and scans being performed for other reasons. So it's an example of a little breast cancer on a liver MRI study for an incidental finding.
If the patient did not have a history of breast cancer and you just, like, sometimes I feel like I see these little incidental things in the breasts, and maybe they're young and they wouldn't already be going for screening and stuff, do you generally still recommend them for ultrasound? Or like if you saw like a little enhancing focus and I'm like, could be a lymph node, could be a fibroadenoma, I don't really know that much about breast MR.
Yeah, I think, first of all, I'm not an expert at this, so I don't know that my answer is going to be like worth anything. But what I do is if it looks like it's a solid mass and I can convince myself it's not a lymph node, then I always put it in the report, and I always call the referring provider and say it's a solid mass, and I have them always seen by the breast care center. If I can convince myself it's not a lymph node. If the person's under the age of like 30, then I'll say it's probably a benign fibroadenoma. And if they're like 35 or higher, then I won't put that in there. I'll just say solid breast mass and then recommend referral to the breast cancer center so they can do whatever workup they think is appropriate. In general, when I find these little masses on CTs and MRIs, I would say a good chunk of them are malignancies. Like, it's not like we're seeing a bunch of garbage. I mean, I'd say well into probably the 30+% of them are aggressive cancers. So I tend to err on the side of probably describing them, and I'm somebody who generally minimizes incidental findings. What do you think?
Yeah, no, that's helpful. I was thinking maybe I was overcalling them and stuff, but that helps me to just keep overcalling them or keep calling them. And also, I don't really look at the localizers, so I should probably start doing that. But our coronal images sometimes go from, like, I don't know, to the patient's knees and stuff. So we often, not on the localizers, but just on our coronals, I'll have to look at the lung apices and the pelvis and stuff. So.
Yeah, this is like, these lines here represent where the axial images were required. So anything that's, for at least on this particular scan, anything that's up here or down here is simply not imaged on any other sequence. So it's a huge opportunity, I think, for mistakes to happen, like apical lung cancers or something like appendiceal mucocele or something, or some kind of lytic lesion in L5. I think we had a patient here who had a recurrent hip pain. This is maybe 5 or 10 years ago now, but it's a famous one, where they had recurrent hip pain. They were a runner, like in the prime of their life, like training for marathon type stuff. And they had recurrent hip pain, and they did a hip CT to look for little fractures, and it was normal. The hip CT was normal. But on the scout images, there was a visible fracture that was just below the CT volume acquisition. So it was like in the proximal diaphysis. and they're like, it's normal. And the person continued to run, and then it like progressed to a through and through fracture of the femur, which is not a great thing to have if you're training for a marathon and you're a young person in the prime of your life, and it results in a lot of like soul searching and QA and that kind of thing. And the thing that burned into my mind from that experience is that really for any scan, for me, I try to remember, and sometimes I forget, I try hard to remember that you got to look at the whole field of view images also, even though they're not this like diagnostically useful a lot of times. And that includes the silly surveys, like this is our silly like localizer sequence. And this covers a bunch of stuff that, you know, you're never going to see unless you look at the sequence. All the stuff up in the lung apices and stuff, all the stuff in the upper thoracic spine, you just never look at that on the other sequences. You're sort of screwing yourself, I think, if you don't look at them. I try hard to remember, but when you're staffing tons of cases, sometimes it's hard to, you know, you guys appreciate that, fellow radiologists.
Yeah, I totally agree with Matt. And I personally make sure that I look at the sagittal image of the spine, because that's probably the only sequence I can look at the sagittal image of the spine on the abdominal MRI. And we had a patient where we found spinal mets on the sag and then worked up. And also there was recently, there was a case of a patient was being worked up for liver lesions, and people were only looking at the liver, and there was one sequence, the coronal single shots, which went down further down into the right lower quadrant, and none of the other sequences were even covering that. And retrospectively, when we went back and looked at it, that was one sequence. There was a mesenteric mass, and the liver lesions were neuroendocrine mets, and the right lower quadrant mass was a carcinoid. And we could have diagnosed that earlier if we were paying attention to that area on the coronal single shots.